just goes out, nothing happens to it and just gets excreted. But at least it separates out your SID to be able to have a more physiological, strong ion dip. Here's a way to look at a lot of the fluids that you give. So normal saline, very acidotic, has no SID. You do get a little bit of dilutional alkalosis by diluting out the weak acid. And then the same thing here with your hypotonic, you're going to get an acidotic and alkalosis. Lactated ringer, it is a little bit acidotic with a SID of 28, but you also get a little bit of alkalosis from the dilution of the albumin, and it ends up being about neutral. And then Normasol, very alkalotic, and you get dilutional alkalosis. Albumin is mixed in normal saline. Those are all going to have a no SID, a SID of 0, but they do increase the ATOT, which make it a little bit more acidotic. So you get acidosis and acidosis, 3% as well acidosis, as well as whenever you give somebody a hypertonic solution, it brings in water, and water also has a SID of 0. And then bicarb drip, which everyone loves. If you give it 3 amps and D5, you'll have a SID of 150. It's pretty solid. And that'll be very alkalotic. So some arguments against this. Why is this important? A true balanced solution will be able to counteract the acidosis from the lower SID with the alkalosis of diluting out the weak acid, the albumin. Lactated ringer seems to be the best to be kind of neutral whenever you give it. So choose your IV fluid based on the patient's pH. If they're very alkalotic, some contraction alkalosis, I think normal saline is fine. If your patient is extremely acidotic and they don't have fulminant liver failure, I think that you could give lactated ringer, or if you have something else, some other balanced solution on. Base excess, that number that you never pay attention to on an ABG, yeah? All right. So it's the amount of strong acid that must be added to each liter of fully oxygenated blood at a pH of 7.4 and a temperature of 37 degrees with a PCO2 of 40. And it gives you this number, right? Base excess, negative 1.8. So it means a negative amount of strong acid, so it means you need some base that are a little bit acidotic. So you can actually look at the base excess with the fluids that you're giving them and see what happens. And this is exactly what they did. So if you look at the base excess, as you give them normal saline, their base excess goes down, right? They get more and more acidotic. If you give them a bicarb drip, you can see that it goes up at a pretty steep angle, and then you have everything in between. So Ringer's lactate's right into here, Plasma-Lite kind of goes right into here, in terms of making them a little bit more alkalotic. Everyone loves to say, can't give lactated Ringer, they have a lactate. So you can't give it. They're actually very different. One's a lactate salt, whereas one's a lactic acid. So it's sodium lactate versus lactic acid, so they're very different. It will raise your lactate a little bit. Unless you're in fulminant liver failure, it'll raise it just a tad. Some people say that's too confusing for resuscitating somebody with sepsis. It's not worth the risk. And to make things even more complicated, the people that spend their entire life dealing with fluid resuscitations, kind of Merrick and Belomo, they'll mention the brief, and they've gone in and said the lactate clearance as a target for sepsis probably isn't that great, which I don't know what to do with that. But that's what. The idea behind it is you can give lactated Ringer unless they have fulminant liver failure. How about bicarb? Is it because of the bicarb? Or is it because of the lactic chloride that is very alkaline? What's your guess?
If you're using a strong ion, it would be
it's the lactic chloride. So the presence of bicarb doesn't matter. It doesn't matter what it is. You could give sodium hydroxide, it's lye, and you would die. But if that didn't happen, you would have the exact same thing. You would get the same results. And the fact that it doesn't matter that there's bicarb. All your body's going to do is take that bicarb, and whatever it doesn't need, it's going to blow it off with CO2. Actually, it's really unstable. A lot of it immediately goes to CO2. That's why a lot of times you see it in glass vials whenever you draw it up, is because if you put it in plastic, most of it will go to CO2, and you're not really giving as much bicarb as you think you're giving. And then where does albumin fit in, right? No one knows what to do with albumin. Some people hate it, say it's the worst thing that's ever happened. Some people love it, and they want to give it. I think everyone's kind of all over the fence on that. The SAFE trial was one that came out in 2004, and that looked at giving it versus normal saline, and really they decided that it didn't matter. Subgroup analysis said trauma patients, definitely not. Traumatic brain injury, increased mortality with albumin. But they looked at the subset for sepsis. Didn't reach statistical significance, but they actually improved with albumin in a septic patient. Something to think about. It's not as bad as people pointed out. All right, so quick tip and final word is that if you want to, just to make things easy, is that if you're worried about the patient's acid-base status, which I hope you would be, give a patient a fluid with a SID that is greater than their bicarb if you want them to be alkalotic, and less than their bicarb if you want them to be acidotic, if you want to do it from that standpoint. So if the patient's bicarb is 10, if you give them lactated ringer, they will become alkalotic. If you give them normal saline, they will become acidotic from an acid-base standpoint with the fluids.
So all of our DKA patients, like, they should all be getting lactated ringer?
You can try to balance. I would say yes, they should be getting more lactated ringers than what we're giving them. I mean, if somebody's hypotensive, you're giving them fluids and you're giving them insulin, they're stopping making keto acids, so they're already going to become less acidotic, and so you're not going to see those differences. But how many times have you redrawn those labs and the pH is the same, not really anything's changed except maybe their gap's a little bit lower? So I think we can be a little bit more aggressive on giving somebody either lactated ringer or consider using something else. I mean, I would say you could even consider giving them, we don't have any balanced solutions down in the emergency department, but if you gave them half normal with an amp and a half of bicarb, then that's an alkalotic SID, and you would actually help them out as well. But you're adding bicarb, which is going to increase their respirations if they're already too small breathing, and people don't like bicarb whenever they do it. So I would say yes, I would give them more lactated ringer. I think a lot of people say like 2 of normal saline and then maybe throw in a lactated ringer at the end. I would say give them 2 of lactated ringer, and then if you're really into giving them normal saline, knock yourself out. I mean, it's a balance. I don't think that there's like you have to do it this way. If you give them a little bit of it, it's not going to matter. It's whenever you give them these large volume ones where you start seeing these big differences. All right, so fluid resuscitation, I would say give a bunch of fluid up front. Continuously reassess volume responsiveness. That way they're not 8 liters positive when they come upstairs and they have to go on like a Lasix drip just to make it so that they can move their arms. Mm-hmm. And then I would at least think about the SID, kind of the Stewart method, and say, is the fluid I'm giving them helping or not helping? You can give somebody volume that needs volume without also making them have a non-anti-GAP metabolic acidosis with the hyperchloremia. Try to maintain a physiological state if you can. Yeah.
So with the DKA, when we give the fluids, a lot of times we give the normal saline, by that point we started them on the insulin drip and the gap is closed, and then we get a repeat blood gas. And we see that they have this hyperchloremic acidosis. Does that translate clinically into something, the fact that they have the hyperchloremic acidosis?
I mean, it seems to, whenever you look at it, is that I don't know if they didn't do a subset analysis on DKA patients, but I mean, there's plenty of papers out there that says hyperchloremia leads to increased morbidity and mortality. Anything that's going to make you, if I gave you something that makes you acidotic, you'd be like, a patient who's acidotic and I said, hey, I'm going to give them an acid. You'd be like, that seems weird. But then you give them normal saline because it's just something that we've always given. So I think that, yes, I think it probably does have some issues with it, but I can't tell you like numbers. So fluid can kill you. It increases morbidity and mortality if you have hypervolemia, positive fluid balance, and if you become hyperchloremic for it. So treat fluid as a drug. Don't just say, hey, I found this bag of normal saline in the bottom container. I'm just going to put it on the patient. We're good. I want you to just think about kind of what you're doing and realize that it does make a difference. Maybe you're not going to see those differences with those small amounts, but in the end, it does make a difference. So if you're interested, it's very much a critical care type of a thing I get, not really so much here because it's long-term stuff and seeing these types of stuff. These people are huge in fluid resuscitation. Belomo, Merrick, Vincent, Kellum. Kellum does more fluid responsiveness. These people are all into fluid resuscitation. Merrick was the one that said the saltwater drowning paper, kind of funny. Actually, this week, what I wanted to show you is that every day they're releasing a new paper on fluid resuscitation. So it's a huge thing that continually to change, and nothing. And you can see all these things. I know it's small, but all these things are echocardiography for the guide for fluid management. 4 phases of IV fluid therapy. Fluid management for critically ill. I mean, they're all things that are still being like worked out and talked about. These are all fairly new concepts to think about. So something that if you're interested in, it's good to read. So yeah, that's